thorax itself, it's symmetrical, looking at the overall skin color, evenly pigmented. Looking at the musculature, it's well developed. I'm looking for any obvious lesions or masses. Looking at the respiratory rate, should be about 12 to 20 breaths per minute, and no accessory muscle use, smooth, even movement on respiration. Looking at the configuration of the thorax, so the AP to transverse diameter is 1 to 2. And trachea appears to be midline. So patient is relaxed, comfortable, arms at their side. I'm going to ask them if they know their name, who they are, where they are, what day it is. So they're A and O times 3. We're going to move on to palpation. So before you begin, you're going to tell me where the apices begin and the bases end. So anteriorly, the apices sit 2 to 3 centimeters above the clavicle, inner 1/3. The bases end at the 6th rib anteriorly, 8th rib laterally, and the 10th rib posteriorly. So you're going to landmark it for me. Now we'll begin with palpation. On the anterior surface, we're going to find the costal angle. Place your thumbs right below the xiphoid process. Nice deep breath in, and the thumbs should separate smoothly and evenly. We're going to palpate for the trachea, so the sternal notch, and walk your fingers up. Should be midline on the trachea. Now we're going to leave the anterior surface. The rest you're going to work off the posterior for me. Okay, so on the posterior thorax, again with inspection, looking at the overall skin color, scapular are sitting in alignment, downward sloping ribs, no obvious lesions or masses. I'm going to do chest expansion on the posterior thorax, so I'm going to find the 12th rib, walk up 2 spaces, place my fingers at around T10, big deep breath in and out, and my fingers should separate smoothly and evenly. I'm going to palpate the entire posterior thorax for any masses or tenderness or crepitus. And then I'm going to palpate for tactile fremitus. So patient cross their arms in front, separate the scapula out using the metacarpal surface of the hands. I'm going to have them say 99, 99, 99, 99, 99. So 5 spots, and the vibration should diminish as you descend to the bases. Next thing we're going to do is percussion. So we're going to percuss 9 areas. So you can find C7, come straight across, and you're over the apices. So 3 spots over the apices. And then we're going to go into our spots. So 2, 3, 4, 5, 6, 7, 8, and then up to 9. 8 and up to 9. So 9 spots for percussion. We should hear resonance throughout. You have an option to do diaphragmatic excursion. If you do diaphragmatic excursion, I'll give you extra points, okay? So that's measuring on inspiration, expiration. So you have the person take a big deep breath in, exhale and hold it so the diaphragm rises up, starting at T7 right below the scapular. You percuss downward till you hear dullness and then mark it. Have the person take a deep breath in and hold it. So now we know that the diaphragm on inspiration is going to drop down. I can go for my first line, down, and then measure. It should be about 3 to 5 centimeters. You only have to do it on one side. You would just tell me that. Normally you do it on both, and it should be the same. After that, we are going to do auscultation. So you would just show me the 9 areas. Okay, we don't have time to auscultate. So 1 over each one of the apices, and then 2, 3, 4, 5, 6, 7, 8, 9, 8, 9. You're going to turn around to the front and name, locate, and describe the breath sounds to me. So on either side of the trachea, we have tracheal or bronchial breath sounds. They're loud, harsh, high-pitched. Short inspiratory cycle, long expiratory. Sternal notch down to the manubrial sternal angle. On second intercostal and third intercostal space is where the bifurcation takes place, so bronchovesicular. Moderate pitch, even inspiratory and expiratory cycle. And then everything else throughout the peripheral lung fields is vesicular. soft, low pitch, like the wind rustling through the leaves, has a long inspiratory cycle and short expiratory cycle. You'd also be listening for adventitious breath sounds, so wheezes, crackles, bronchi, any of those. I'm going to ask you then that if you heard, for example, bronchovesicular breath sounds at the right base, what additional tests could you do? And you get to choose which one. You can do egophony, bronchophony, or whispered pectoriloquy. I don't care which one you do. So if you were doing egophony, you'd have the individual saying E, and as you're listening, E. And normally it should be what? A muffled E sound. If you hear a bleeding A sound, you know that something's enhancing the transmission. With bronchophony, muffled 99. If you're hearing it clear and distinct, something's enhancing transmission, so usually a solid or a mass. If on the whispered pectoriloquy, it's 1, 2, 3. Whispered should be muffled, distinct. That's an abnormal finding. All right, so after respiratory, we're going to lay your partner down. Okay, you're going to name and locate the 5 precordial sites, so sternal notch down to the manubrial sternal angle. Second intercostal space to the patient's right is the aortic. To the left is pulmonic. Third is the Erb's point. Fourth and fifth is the tricuspid, and then fifth, mid-clavicular line is the mitral area, or where the PMI, or point of maximal impulse, is. So we'll begin with inspection. Over the precordium, the overall skin color is good. There's no even pigmentation. There's no lesions or masses. I'm also going to get down and inspect for pulsations. And I'm also looking for any lifts or heaves. I might be able to see the apical impulse on a thin male. Otherwise, I'm not able to visualize it. I'm going to palpate starting at the base. I'm palpating for lifts, heaves, thrills. So again, using that metacarpal surface. A thrill is a vibration. Along the left sternal border and out to the mid-clavicular line. I'll take the point of maximal impulse and take the PMI while I'm out here. We don't percuss. The next thing we do is auscultate. So you would tell me that you would listen to all 5 areas, bell and diaphragm, sitting and lying, listening for S1, S2, the rate, the rhythm, any extra heart sounds or murmurs. But for the test, you will pick one area and just we'll listen together in that area. So your choice. If you pick the pulmonic, I'm going to ask you what's louder. S2, that's the one we'll tap out. Tricuspid mitral, it's S1. We'll tap out S1. Your choice, okay? So I would pick the one that I could hear the best of my partner. That's the heart. Next thing we have to do these 4 imaginary legs and arms, okay? So we're going right to peripheral vascular. We're going to begin with inspecting the upper and lower extremities, looking again overall skin color, looking for any cyanosis in the nail beds, any obvious lesions or masses, looking for muscle atrophy. On the lower extremities, in addition to that, I would be looking at the hair distribution, and I'd be looking at the venous patterns as well. After inspection, we're going to palpate the upper and lower extremities for temperature. The dorsal side of the hands should be symmetrical throughout. I'm going to palpate for capillary refill, less than 2 seconds on the nail beds and the toe beds. I'm going to have them dorsiflex their foot. Negative Hohmann sign, there should be no increased pain. And then I'm going to palpate the pulses. So temporals, carotids, one at a time. I'm going to do the brachials, the radials. I'm going to do the femorals, popliteals, dorsalis pedis on the medial aspect right above the ankle, and the posterior dorsalis pedis on top. After the pulses, I will come back with my stethoscope and I'm going to listen over the carotids, all right? So base of the jaw, mid-cervical, and the base of the neck for any bruits. That's it.
Thank
Get
you.
anything?